Okay, guys, sorry, better late than never, but I wanted to do my presentation um, for our data class. So I'll go ahead and get started now. Um, so my project has been, the time that I've been spending for our data class has been spent working on the research component for my capstone, which for those of you who are not aware, my capstone presentation and capstone project is on doing a research study in Rwanda around medication abortion. So we'll talk a little bit about this through this presentation. I'm going to first talk a little bit about abortion laws in Rwanda, about the conditions of unsafe abortion, about medication abortion, which is specific to the study that we'll be doing, my capstone, the process in which we're going to collect data, and then I have questions for you guys. Initially, on Sunday, I had planned this presentation to be less of a formal presentation and more of a facilitated discussion where I was going to crowdsource you guys for collecting information about my research component. So currently in Rwanda, nearly half of pregnancies each year are unintended, and that has to do with a lacking infrastructure and funding for birth control and widespread access and information to birth control. As you can see in this data, in 2009, there were 587,000 pregnancies, 10% of which ended in induced abortion. Where a large chunk also ended up in delivery. So currently in Rwanda, women are having, on average, like 5.25 children per family, which is much higher than a lot of the developing nations. Currently, abortion is legal in Rwanda. In 2009, they passed a very restrictive abortion access law, allowing abortion to be attained for a woman or provided to a woman after obtaining signatures of two physicians stating that it was necessary to protect her life. Within the country of Rwanda, I think there are 6.1 million people. And there are very few hospitals. I think there are 8 major hospitals. There are very few physicians, and the chance that someone would have an opportunity to seek care from one physician is hard enough, let alone seeking counsel and time with 2 physicians is nearly impossible. So in 2012, they opened up the grounds for the access to legal abortion to include cases of rape, incest, forced marriage, and fetal impairment. And they have done away with the 2 physician requirement, although in these cases, rape, incest, forced marriage, and fetal impairment, there needs to be medical or legal proof that these happened. So even though abortion is legal, the access to abortion is rare. So in 2014, there was data collected from a gender-based violence clinic in Kigali City, which is the capital city of Rwanda. 16% of women were pregnant due to rape, incest, or forced marriages, and none of these cases ended in legal abortion. And I asked myself and asked the docs that we worked with why that is. And clearly, this has to do with a lacking infrastructure for legal abortion, but also there are not many providers trained to provide legal abortion in the country. So what happens? Unsafe abortion happens. So in Rwanda, there's the same amount of abortion happens at the same frequency and in Rwanda as it does in developing nations. It just means that the majority of abortions provided in the country are done illegally. Less than 5% are performed legally. And of that, most are happening in privately funded doctor's offices. It is only something that is accessible by someone with financial means. Not only is unsafe abortion a risk for women physically, and it is the fourth leading cause of maternal death um, in the country behind pregnancy related conditions like preeclampsia. It also is a legal issue. So, women who are trying to obtain or have been found guilty of obtaining a legal abortion can face prison sentences of 1 to 5 years, and and there are even stricter prison sentences for people providing illegal abortions. So 25% of Rwandan's female prison population are related to abortion-related convictions. So it brings us to talking about medication abortion. The World Health Organization had named medication abortion the gold standard or the best option in developing nations. And that had to do with medication abortion being a safer form of pregnancy termination in areas that are that have restricted access to skilled, trained providers, safe and clean facilities, and decreases the risk of things like sepsis and death related to abortion. Misoprostol is currently available for use in around 100 countries. It was first found out in for its we first found out the use of medication abortion from the sex industry in the Philippines. The medication was originally approved and is still being used widely to prevent ulcers from developing in the stomach and digestional tract of women who, or of all people who use, chronically use NSAIDs. So traditionally used by an older population, which is why they didn't make the correlation to it being used for abortion initially. It was folks with chronic pain conditions like arthritis would take it to stop the ulcer development. But they did find that women in the sex industry were often using NSAIDs as an outcome of their occupation. And what they did find was that women who used misoprostol in low doses in early pregnancy were seeing high levels of miscarriage. And it really trickled from there. So it was commonly used in the 1980s in France and in Europe in a whole. It was approved for use in the United States in the 1990s and has disseminated to other countries worldwide. Which brings me to my capstone. So as I was preparing for my capstone process, I was looking at, as a whole, what are the problems? What problems do I feel kind of passionate about? What is there? What is something that I feel like I have the drive and the know-how to help to influence some change on? And before I started graduate school in 2016, I was approached by a doc that I work with to help support training of medical providers, docs in Kigali City, who were seeing women who present in hospital as an outcome of unsafe abortion, and how to help support training them to provide care to these women. We are planned and executed a trip. We ended up working with 27 medical providers, both male and female. And what was most striking to me about working with these docs was that in the United States, we're often having to frame abortion as women's or sorry, frame it not as a women's issue, but as a family issue or as a cultural issue. In Rwanda, that wasn't the case at all. The base knowledge for them was that abortion is access to contraception, access to abortion, access to the information around family planning is a basic human right, and that it's a family issue, that these were their mothers and sisters. And I found this to be, especially for a country where abortion choice procedures are illegal, I found this kind of level of understanding and compassion and unification really inspiring. So as I got a little bit closer to doing my capstone, it really felt, I just kept being drawn back to working within Rwanda. So as I was first looking at the possible interventions, I was looking at some really large-scale options on the table, including opening an abortion clinic or working with the providers to do training with patients in the hospitals. And I really needed to ask myself kind of some basic questions. So, how do you aid change in communities where you don't live? How do you actually affect change this far away? And really what is needed to kind of host conversations about what people in Rwanda want and need. So I approached a doc that I worked with in our first trip and has stayed in touch with, and scheduled a conversation with him. And the more and more we talked, the closer we got to, and the more we looked at the information available, there was a glaring gap in the data. There was data from 2014 on surgical abortion and access, but there was absolutely no data around medication abortion. And I think that is because, not because medication, misoprostol and medication abortion was not being used in the country at the time, but because because there is no national protocol, every single one of those uses would have been illegal. And doing research on illegal abortion is risky business. So how do you do that? With data. What we found the most respectful leverage point to be was to plan and execute a research study to, at the very least, confirm that medication abortion is being used within the country of Rwanda, in hopes that it could help to influence the community conversations moving forward around a national adaptation of a medication abortion protocol, both to support the providers, but also ultimately to support the women of Rwanda. So now our slides get a little heavier, but this is where I feel like I need your input the most. So our main question and hypothesis, is there qualitative evidence Rwandan women are using a medication abortion to terminate unwanted pregnancies? So we know that there's no data, there's no national protocol, but we have accounts from providers, medical providers who have suspected this. We also know that abortion rates are decreasing as a whole, and we hypothesize that information about medication abortion is becoming wider spread, and we know that these medications are available through alternative routes, not just through national protocol or pharmacies, but for purchase online. So in 2018, a research team consisting of myself, the doc, Renee, and one Rwandan healthcare provider will conduct research both in Kigali and in surrounding rural settings. Our research will be qualitative, so we're going to be collecting stories from healthcare providers about their experiences serving patients who are presenting in hospitals. We aim to survey 10 medical providers who have practiced for at least 5 years, so that they can help to identify trends, not only in the number of hospital admissions related to unsafe abortion, but the histories collected from the patients, and if there's any self-admitted use of medication abortion. We also are going to look and ask questions about trends around hospital admissions related to things that look like miscarriage management. If we go back a few slides, we know that miscarriage happens in about 7% of the unintended pregnancies, and we see it in about 9% of the intended pregnancies. But the way that medication abortion is used is it allows women to take the medications which cause symptoms that mimic miscarriage. So we suspect that that data should shift over time as women are using these medications and presenting in hospital for follow-up that'll look like miscarriage management. We also know that we have that there is economic disparity between the urban and the rural areas, and so we want to be getting perspectives of providers both in and out, but that there is a higher likelihood that we'll see medication abortion trends in the urban areas because they're the people who are most likely to be able to afford the medications necessary for termination. My capstone will end in August. So my deliverables for my capstone are to plan and execute this trip, to put in abstracts to present at conferences, but we won't actually, and then to actually conduct the research. We'll be analyzing the data and presenting at the conferences, fingers crossed, after capstone has finished. So a few things that kind of we were weighing alongside of this research. We know that qualitative data is open to interpretation. We know that abortion is a difficult topic to discuss, and that we know that there are other underlying factors. So decreased numbers of abortions happening in the country is not necessarily indicative of a higher usage of illegal, safer abortion options, but it can do with jump in contraceptive access. It can do with the dissemination of information. It can do with access to travel means to other countries. We know that abortion-related complications have increased between 2009 and 2013. And in 2013, there was little data to utilize as a leverage point. So we also know that they've seen a huge increase in contraception for married women from that time. So it's jumped from 4% to 44%, which is pretty astronomical. We also know that abortion can be a really scary issue to talk about because of the legal ramifications. So one of the things that we are going to, that we're paying close attention to is the protections in which we're putting in place to protect the participants of the study. We will not be asking any of the participants about their own abortion history, about helping women access illegal abortion, and we will not be linking any of the interview data to specific hospitals because I think the communities are too small. And we know that women, found guilty of having abortions face, jail time, but they also face, fees equivalent to of $300 US, whereas the majority of the population in Rwanda earn about $1.25 per day. So those are our considerations. So my questions to you, and interested in any of your feedback, is what is it that I'm missing? What do you perceive as the risks in collecting this data? How do I leverage the data to be used for growth and development versus being used to support higher abortion restriction? And what feedback do you have on my research methodologies to ensure that the product that we're putting out to the world and the quality of the data is strongest as it can be? So this is my presentation. Thank you. Again, I'm so sorry that it was so late on this project, and I wish you all well. Thank you so much. I'll talk to you soon. Okay. Great.